just really enjoy spending time with the students at SMI each summer. And it's always encouraging to us just to share and, um, encourage each other to engage in ministry in our workplace and to have that be more integrated rather than siloed areas of our lives. And it's really fun to brainstorm and work on that together and encourage each other. So I miss being physically present with you guys, but still good to see some of the faces. I don't know how to see everybody, but I see like 9 people on my screen. So a little bit about myself. I am a geriatric fellowship program director at the University of Pennsylvania in the Perelman School of Medicine. I'm also the aging theme course director for the med school. I direct the geriatric curriculum for the family medicine residency program, and I teach the internal medicine residents geriatrics. I'm a medical director of a nursing home and getting involved in some health system leadership stuff in terms of COVID and nursing homes for Southeast PA in conjunction with the Department of Human Services. We should hear about a $30 to $60 million grant today or tomorrow. And I've been at Penn for 11 years now, which is really mind-blowing to me. I graduated from the University of Michigan Medical School in 2000, did a family medicine residency in Chicago. And I'll be honest, I wasn't a big fan of medical school. I didn't really like it. All sorts of reasons why med school and the culture of med school didn't fit me. And so that's why I did residency at a non-university based residency program. And I always wanted to do geriatrics. I thought I would do geriatrics, join a private group practice, and see nursing home patients and have an office practice. Got married in 2003. My wife did her residency at Geisinger Medical Center in pediatrics, where they did not have a geriatric fellowship program. So I was a solo practice doctor in a town of 950 people called Shikshini, Pennsylvania, which was a hoot. I did 6th grade physicals and football team physician, and I went to the delivery room to take care of babies, took care of patients in the ICU, did house calls, did nursing home visits, did everything except for deliver a baby, and did my geriatric fellowship afterwards. And when I finished my geriatric fellowship, I realized one thing that I wanted to do was teach, and I had to decide how much teaching I wanted to do. Did I want to be in a private practice where I had a student with me every so often? Did I want to be in a community-based residency program where we had residents, but maybe not a lot of medical students? And I decided I wanted to be in a full-fledged teaching environment. And the job that I was offered at Penn was really the only job that I was offered in a teaching environment like that. So I took it, and I've been here ever since. And I never planned on an academic career. I always thought I'd be in private practice. And unlike a lot of my peers that have planned and have aspirations of being in academic medicine, this is something that's kind of happened by default. So I came in 2009 as a clinician, was asked to do some teaching, was asked to do more teaching, and it's just kept going, where now education is a huge part of what I do. So it's been really fun. It's been very unexpected, but it's also been super enjoyable. And I love being a Christian in an academic setting. It's really interesting to me. It's also challenging because being a conservative evangelical Christian that believes, that life begins at conception, that God has sovereignty over our relationships, including our sexuality. There are some things that are, let's say, a little counterculture to what current academic medicine is like. On the other hand, there are things that are very obviously additive and essential to what I contribute as a Christian in academic medicine. The idea that every person is made in the image of God is core to what it means to believe in God, that God created people. in his image, and that every person is fully dignified, no matter what race, what sex, what diseases, what their type of brain development might be, that every single person is fully and 100% dignified and fully valued by God, that God loved each person so much that he died for them. And that we treat each person with that incredible level of dignity is ahead of where our society is, to be honest. It's ahead of where we dignify people. It's a sense of justice that is beyond what most people think, because it's so complete. I think the other thing in academic medicine I think a lot about is everybody is always trying to be as smart as they can possibly be, um, sometimes at the expense of kindness. And for a Christian, being smart is wonderful. Being loving is also amazing. And being kind and trying to win people and not win arguments is very counterculture to what we are like nowadays. And Christians think about things like forgiveness and building relationships and not just winning arguments. And that is so necessary in our culture, where I feel like when I watch people interact, I just feel like people are always trying to win arguments instead of trying to win people. And, Jesus put it best that we are fishers of men. And that is what a Christian can also bring to an academic environment. Um, I was going to show a tweet. There is hostility, I think, sometimes when people think about Christians and academics. Um, I take fairly conservative views on a lot of things. I believe in the Bible, certainly as the Word of God and as authoritative. And as if you wonder, I also never doubt whether or not Christians are intelligent. What's really funny to me is, despite being surrounded by amazingly intelligent people, the smartest people I have always known have always been pastors. The people that help me have insight into this world, that help me predict future behavior of other people, that help me understand why people do what they do, and help me understand why I do what I do, have always been pastors. And there is an incredible sort of sacred wisdom that comes by having a relationship with God, that having the highest IQ score in the world just doesn't seem to get you there. Um, so it's funny, despite having been at Penn for 11 years, with people that are internationally recognized in various fields, they still do really stupid things sometimes. And it's really, it's really interesting to me that what my kids do in Sunday school would be profound lessons within a med school setting. Um, for example, on a Sunday, when I was doing inpatient rounding, I asked the team if they had ever, in a medical setting, discussed the necessity of forgiveness, and if they could even define forgiveness for me. And of course, nobody has, right? It's like discussing love in a medical education setting. Everybody looks at you kind of funny. But you try building an interprofessional team, a functioning interprofessional team, where you never discuss forgiveness. Can't do it. Can't do it at all. And so some of these core concepts of that we learn through flannel cutout pieces in first grade Sunday school class end up being something that is so profound among these really smart people. And it just affirms to me that the wisdom you learn in first grade Sunday school class, that the foolish things of the world, um, or the foolish things of God are wise to the world, or whatever the saying is, that God's wisdom is profound from the get-go. And I think that's there's a confidence that you should bring as a Christian into an academic setting, because you understand what God's wisdom brings to this world. So one of my jobs as a Christian in an academic setting is to engage, is to move towards people, right? So when you look at how Jesus dealt with every single person in this world, he moved towards everybody. So whether it was the self-righteous rich young ruler, He loved him and moved towards him, what Mark wrote, right? He didn't get offended. He didn't cancel him. He didn't block him on Twitter. He moved towards him. When he dealt with the Pharisees, he moved towards them. I mean, with curses and woes, but he still moved towards them. When he had the Samaritan woman, he moved towards her. When he was dealing with drunkards and prostitutes, he moved towards them. When he was dealing with a tax collector that was part of the Roman structure, he moved towards Matthew, the tax collector. Jesus never moved away from anybody. Although some people probably would have preferred that Jesus moved away from them because he always spoke the truth. But Jesus never split up people into a binary. These are people I spend time with. These are people I don't spend time with. He moved towards everybody, and everybody ended up in one bucket, which is these are people that need my salvation, right? So that's how we approach people. And in an academic setting, as a Christian faculty member, one of my jobs is to move towards people. And so that's what I do. One of the ways I do that, I do a ton of teaching. I teach on geriatrics. And like, for example, for the medical students, every year in the spring, I give a talk about how to be caring to caregivers. Okay. So it's an interesting discussion. It's a lecture that I had inherited from another faculty person. And it was a lit review, right? So you go over the literature about caregivers and what caregiving is and what it means and how difficult it is and the health effects on caregivers and the interventions and the tools that we can use to make caregiving easier. And ultimately, though, the question is, how are we compassionate towards caregiving, towards caregivers? And as I gave this lecture year after year, it kind of dawned on me that a lit review never makes anybody a more compassionate person, right? So if I read an article in JAMA, I don't walk away saying, oh, now I'm more compassionate. Now, if we read our Bible, we do. If we interface with God, we do. If we gaze on who Jesus is, we become more compassionate. If we enter into a relationship with God, we become more compassionate. If the Holy Spirit indwells us, we become more compassionate. And so I'm like, good grief. I can't make medical students more compassionate. And so, for example, I started ending my lecture with 1 Corinthians 13. And I said this to the class. I said, I don't imagine that a lecture doing a lit review will make anybody in this room more compassionate, but I'll share with you guys what has made me more compassionate. And I always end with knowing that I have been loved fully allows me to love others. And the dean of diversity and inclusion is sitting there, and the other faculty preceptors are there, and all the medical students are there. And it's interesting that I've never had anybody say anything negative out of the thousands of medical students. We have 160 med students a year, and I've been doing this for 10 years. That not one negative comment has ever filtered through formal or informal channels as I engage. So this is a lecture that I also give. What we're going to do over the next, let's say, 30 minutes is a lecture that I also give to family medicine residents. And the way I came across this was my former division chief, Dr. Jerry Johnson, is a African-American man, physician whose area of research interest is the health disparities in the older African American community as it pertains to palliative care at the end of life, and the ineffectiveness of the traditional medical system at reducing that gap. So Black older adults in America are less likely to get hospice services or more likely to have care that's discordant with their wishes, that causes suffering. They have lower quality of life scores at the end of life. And the question is, how do you bridge that gap? Now, in West Philly, 90% of the older African American population is Christian and attends service on a monthly basis. So within the West Philly African American community, older adult population, there's a high level of Christians and religiosity, which is the practice of religion. And so he's developed a community-based research program that engages church leaders and church lay leaders to engage the African American community through a spiritual framework to see if that can shift the practices of palliative care at the end of life in older African American communities. This is a nationally funded grant research project. And as part of his research project, he had to discuss, well, religion and medicine. And so he did a lit review that sort of opened my eyes that there's a whole literature on religion and medicine. And it's not about, does prayer help people live longer and prevent death? It's just a description. So we're going to go through that today. And the reason it's worth going through this is one of my goals is to help Christian students realize that it's not just the patients you're witnessing to, it's your peers, it's your attendings and professors, it's the other staff you're working with. And sometimes I feel like Christian students get this idea that they have to get through med school and then they can engage in a health career where they can be an open and good witness for Jesus. And the answer is that happens while you're in the middle of an academic setting. And learning to engage the academic culture, I think, is what it means to be a good Christian citizen in an academic environment. And this is one example of how I do it. It is very academic, but it also is very Christian, as I hope you will see. Any questions before we go into this? So I have found that it is challenging to have interactive small group lectures over video. I don't know if it's the verbal cues, like the silent, and person raising their hand. So one thing that I can do also is monitor a chat. And in some ways, I found that the most interactive video small group teaching sessions, there's a fairly active chat going on during the teaching session. I actually may miss some comments, but that's perfectly fine, even if you guys are chatting with each other. But so that's one option. I don't know. I think we're all still feeling it out, how to be good online small group Zoom teachers or Google Hangout teachers. But I'm going to get a lot of practice doing this. So let's give it a go. All right. So I need to share my screen, present now, my entire screen. I wonder if I can do a window share. All right. Can you guys see that? All right, cool. So I also emailed you guys the handout, or you guys will get the handout. And the handout, I realized I forgot to print it out for myself. Hold on just a second. Okay. So the handout has several sections to it, and this PowerPoint summary slides is a summary of the handout. One thing that you can do with this handout is certainly learn it. One is it's meant to be an encouragement that Christians and discussing religious things absolutely has a role within a medical environment and a medical education environment. Actually, one question I want to ask before we get too much further is, has anybody gotten pushback about discussing spiritual things? I know most of you guys are preclinical. There's some folks in med school, but I'm going to guess early on in med school, and then some pre-med students and nursing students and so forth. But has anybody gotten any pushback, like from a specific professor or attending, or even from a course director?
I actually did when I was in medical school. When I was doing psychiatry, the introduction to the rotation done by the chair of the psychiatry department essentially said that anyone who believes in God is delusional. So, yeah. And then I've gotten pushback on just, you shouldn't be pushing your beliefs on somebody else. So yeah, that's the kind of pushback I've gotten.
And I got pushback, or observed some pushback, not on religion per se, because I did medical school in the Deep South in the Bible Belt, so it was perfectly fine to discuss that and talk about that and pray. But some pushback on specific issues where, you definitely can't presume that anybody is pro-life anymore necessarily, and or maybe hesitant on some palliative care that might promote a person's demise, that kind of thing. So when those kind of questions were brought up, the attendings were, you're just a student. We don't care what you have to say. This is what we're going to do. That kind of thing.
Yeah. I mean, I think there's overt curriculum. Every so often you get a medical school that teaches that chaplains do the spiritual discussions with patients. We don't. I think that's less of an issue. It's more that students receive what's called the hidden curriculum, which is sometimes not so hidden, that attendings will make comments, or residents will make comments. Residents seem so old compared to students from a student's perspective, but I'm a PGY 20 or 21 at this point, and it all blurs together. But yeah, there's some pushback. I just saw a Twitter feed that being pro-life has nothing, that people who are pro-life shouldn't even be in medical school, which got just a huge number of likes and comments to that end, posted by a student that I follow. And on the other hand, on my same day, I saw a Twitter article posted about Francis Collins, who's the head of the NIH, and how he became a Christian during medical school, and why he thought that his only conclusion to thinking of this was in the, I can't remember which newspaper it was, but why, maybe the New Yorker, why, after thinking about the human body and what its implications were, and suffering and so forth, that the only answer is that God had to be real. So it's interesting. Anyways, on to the presentation. So when I do this as part of a geriatric assessment talk, and these are sort of the domains of geriatric assessment, and I always emphasize that spirituality is one of the domains. And the question for a lot of residents that I teach, and I say, do you ask your patients about spirituality? And hardly anybody does. It's one of those questions that I would say people who are not terribly religious find very, very awkward. And the answer that I get from a lot of the atheist residents is, especially because we're in West Philly, is they say they hate asking the question about like church and religion and spirituality, because invariably they have some patient, who looks at them and says, I believe in Jesus. I would love to know that my doctor does too. What's your beliefs? And then the atheist residents find it very awkward how to respond to that. And so I find that I'm often guiding the atheist residents how to engage in spirituality. And that's a really common question I get from students and residents who don't have any spiritual background. And it's really interesting. It's very neutral. They're like, I just never grew up with anything. And when patients ask me my beliefs, I don't want to be offensive. I don't want to say that, well, I don't believe in God. And so they ask me about how to engage patients back. But the issue in the US, and I think the thing that we have to recognize, is that most people believe in God. Most people believe in a spiritual aspect to our world. This comes from multiple surveys, such as Pew Research surveys, formal studies in the medical literature where they interview patients. And most patients say they believe in God. Most patients say that they pray. 2/3 of patients, and it depends, it would be higher in West Philadelphia, but 2/3 of patients are members of an organized religion, and 40% attend religious services at least monthly. Like I said, in the older African-American population in West Philly, it's 90%. And almost 80% of patients believe that spiritual faith can help people recover from illness, injury, and disease. And the issue there is between patients and physicians, there is a gap where still 64% of physicians believe in God. Sometimes when I'm hanging around at a place like Penn, it seems like it's less than that. Certainly it seems like people act like it's less than that. And in some subspecialties like psychiatry, for example, it's even lower. And so there is a gap between patients and physicians where patients are more spiritual than physicians, generally speaking, and it's bigger in some specialties and lower in other specialties. I think all of healthcare is about crossing culture gaps. And we talk about crossing the culture gap of race and doing so thoughtfully and with compassion and with expertise. We talk about crossing the culture gap of sort of gender identity and sexual orientation, and how do we do that using the right terms and with the right language. We talk about age gaps and other types of culture gaps, but there's definitely a spirituality culture gap between physicians and patients. So our patients are religious, and interestingly enough, they actually expect physicians to engage with them on spirituality. So this comes from a variety of surveys. And the nutshell is for better understanding, for better relationships with doctors, to help them make healthcare decisions, to access resources that help them cope with illness, and spiritual needs or a lack of spiritual resources leads to health needs and poor coping skills. I just came across an article on spirituality and COVID, which is amazing how many articles on COVID are coming out every day. I did not get a chance to read that yet. And I think the last thing I want to leave you guys with is that discussing spirituality is a standard of care from a medical school, residency, and a practice perspective. So patients want to be asked. So depending on the context, they do these surveys in a variety of ways. They do waiting room surveys where they hand out a survey to patients in a waiting room for an office visit. They hand out surveys to patients who are in a pre-op area for their surgery, patients admitted to the hospital, patients who are newly diagnosed with serious illness, and they, in a variety of settings, so for example, outpatient, inpatient, rehab, or nursing home settings. And generally speaking, there's a range. The more minor the medical problem, the less likely somebody wants to be engaged about spiritual issues. The more serious the problem, the more they're in a serious healthcare setting like a hospital or even an ICU setting, the more likely they are to be desiring that type of interaction with their physician. And certainly in a death and dying setting, the rates go really up. I think, do I say this? Yeah, I do. What you have to recognize is it is not 0 and is not 100 in any survey whatsoever. And so everybody will talk about anecdotes. I mean, I hate a purely anecdotal practice of medicine. You do really crazy things, but everybody will have anecdotes of times it has gone poorly, and people will have anecdotes of where it goes well. And what you'll come across as a student is you'll have a resident or attending give you an anecdote of when it has gone poorly and say, therefore, you should never engage on this. And that is true. I mean, I've asked people about their smoking history and have had that gone poorly. I've had people where I asked this one person if they live in an apartment, a one-story house, or two-story house. From a geriatrician's perspective, functional status matters a lot. And if somebody lives in a studio apartment where they can get around with a walker, that's really different than if they live in a two-story house where the bathroom's just on the second floor and they also use a walker, then that's a problem. But the person was so offended that I was trying to stratify them financially. They actually never came back to see me again. And I tried to explain during the office visit that I'm just asking about functional history. And so there's always these sort of awkward topics, but one of the jobs of a healthcare provider is to make awkward things less awkward. I said that to a student, and he says, "I always feel like I make things more awkward." But, but it is through practice. You learn to normalize all sorts of things. And one of the things that we need to normalize is bridging the culture gap of spirituality. So, one of the really interesting things that I now pay attention to is when somebody tells me they don't ask patients any questions about spirituality, I always ask them why, because invariably they have some issue with spirituality. It's not really the patient's reaction. It's just that the patient's reaction confirms their own reaction. And so I often find that it is a way for me to engage my colleagues. Uh, Probably the least offensive question that I've learned to follow up some sort of culture gap issue is just to say to somebody, tell me a little bit more about that. Comes across as pretty non-confrontational when you're trying to bridge a culture gap. But yeah, just like smoking, just like sexuality, just like finances, family relationships, a lot of the social history questions we ask, do you drink once a day, once a week, once a month? Have you ever had problems with seizures when you try to stop drinking? A lot of these questions we've learned to normalize and ask in an appropriate way. And spirituality needs to be one of those things as well. Now, the early surveys on religion and medicine asked the question, do you want your doctor to talk to you about religion? Which is really amusing. And the answer was about 5% people would say yes. And one of the studies that was done at Penn by a chaplain named John Amen, who still works as a chaplain at Penn, he contextualized the question to say, do you have spiritual or religious beliefs that would influence your medical decisions if you became gravely ill? Can you guys hear my son? He's chatty. Okay. So when John Amen, and this study's been quoted over 300 times because the magic of the question is you contextualize it, right? So if you asked your patients, can I talk to you as your doctor about politics? People would say no, right? Or if you said, can I ask you how you're going to vote? People would say no. But if you say to people, um, I'm worried about your ability to vote this November because of your functional status and because of the risk of COVID, would you like assistance in signing up for mail-in ballots? That has been very well received among our patients, right? So if you contextualize things, then it makes a lot more sense. And what's interesting about this question is, even though people mark no sometimes, half of the patients who said that they did not want to, that they did not have spiritual or religious beliefs that influenced their medical decisions, half of those still felt that physicians should ask. So at the end of the day, there were probably about a couple percent of patients that felt that physicians shouldn't even ask. But the vast majority of patients felt that physicians should ask, even the ones that had no spiritual or religious beliefs that would influence their medical decisions. And so this is a great example of how research can help you ask a question in a more thoughtful way. So again, what does it do? So in the same survey, when patients were asked, why would you want your doctor to talk about this? One is it helped them feel understood. It gave them realistic hope. It might actually change their medical advice. 2/3 would say it would increase trust in their physician. 62% it would change their medical treatment. And 33% were hoping that the doctor would pray. So patients have these inside thoughts, and they don't share it with the physician. Physicians also have inside thoughts. A friend of ours whose mother has metastatic cancer, they always get this sense that the doctors are implying things and they can't quite understand what the doctors are trying to say. We like to think that we get past middle school, but there's this awkwardness to the patient-doctor interaction that just kind of persists forever. But this is where patients are. And in JAMA, this is an older article, is written by a guy named Bernard or Bernie Lowe, who was actually the author of the Institute on Medicine Dying in America report. He wrote that discussing spirituality helps a physician understand patient needs, provide respectful, comprehensive end-of-life care. He's a palliative care doc. And it can help the physician understand how a patient is thinking. It can keep them from feeling alone. And patients who do not feel understood may have other unexpressed concerns. And so this becomes a relational area, right? So if you, for example, have a patient that you're treating for hypertension, but they're dealing with violence in their home care setting, and you're saying, well, why can't you take this medication 4 times a day? And you're not asking if they can afford it, if their life is stable enough to adhere to a high-level complex treatment. You're never going to succeed. And in the same way, if a patient comes from an area of spirituality, and it's a very important area, and it just gets flat out ignored, then your attempt at getting them to engage in the healthcare system, there's going to be a gap. So this comes from CHEST. CHEST is a pulmonary journal. It says clinicians have a moral obligation to attend to their patients' spiritual needs. First, if physicians and other healthcare professionals have sworn to treat patients to the best of ability and judgment, and the best care treats patients as whole persons, to treat patients in a way that ignores the fundamental meaning the patient sees in suffering, healing, life, and death is to treat the patient superficially and fall short of the best ability and judgment, right? So these are critical care docs, not, in my opinion, having the reputation for being the warmest and fuzziest type of doctors. But this is an argument proposed in the CHEST journal. Lancet, again, some of the references are a little bit old, maybe older than you guys. A thorough understanding of a patient's religious values can be extremely important discussing critical issues such as end-of-life care. Irrespective of the practitioner's religion, respectful attention must be paid to the impact of religion on a patient's decisions about healthcare. So I have a couple of Christian patients, actually a lot of Christian patients, some of whom go to my own church. And one thing I say to them is, I want your code status. Are you full code or DNR? And your end-of-life advanced directives to be an expression of your faith. I want you to consider what your medical decisions are in context of your faith. It's important to me to integrate that for my patients that I know are very spiritual. So one, again, is that patients want to be understood. Another is that they actually incorporate spirituality into their decisions. So 45% of patients say that religious beliefs influence their medical decisions. To understand a diagnosis, whether to pursue treatment, and guilt. This was big, for example, for HIV in the 80s and 90s, where people felt like they deserved their HIV, in part because the evangelical church set up that as an attitude towards HIV. In some ways, Christians made this guilt worse, and sort of failed to understand the redemptive nature of medicine overall. You know, a lot of times as physicians, we think if we talk to patients enough and educate them and bring them through medical school, they will think the same way we do. Whereas patients are thinking about their medical decisions from a different angle. They incorporate medical decisions into how they cope with an illness. Most women in this study on breast cancer said that religion helped them cope with their cancer. In a melanoma study, again, those with spiritual beliefs were more likely to use active coping skills. And spiritual well-being in a hospice study was the main thing that predicted good quality of life at the end of life, using certain surveys given to both the patient and to the family. So in the Annals of Internal Medicine, in a position paper, they said, that the support of hope should fall within the purview of the physician. And I think that is a true statement broadly, and certainly in regards to spirituality. Now, the flip side, so that's what we would achieve if we were to fully engage patients on the spiritual aspects of their lives. Neglecting it has been likewise in the literature shown to be harms. And so in the handout that Holly will email you guys are the references for all these articles, and you can look those up later. So most patients cannot recall being asked in a healthcare setting about their spiritual beliefs. The way I usually ask it is, are there any spiritual beliefs or cultural practices that you would like me to know about you as your physician? Things like diets or customs that might impact your healthcare. And that's just a routine question I ask every new patient. But most patients have never been asked about these sort of things. And they have high spiritual needs that are missed, and that has been found in surveys. And this survey has been done, or these type of surveys have been done again in every site of care. And there are some really heartbreaking examples of what happens when we miss it. So there was an article in the journal Pediatrics where 172 children died after parents relied on faith healing. And most of these children died from treatable illnesses that if their providers were able to bridge that spiritual culture gap, most of these children would have survived. And so this was an article that highlighted that not addressing spiritual needs actually leads to mortality harm for our patients. There are really interesting articles on medication adherence where if you can reframe let's say treatment for HIV within a spiritual context, whether it is a Christian, church-based HIV clinic, or you reframe hypertension treatment and you bridge that with spirituality, that you can improve adherence. And if you don't, it can lead to lower adherence. Let's see, how am I doing on time here? Let me just make sure there wasn't anything else. Yep, let's keep going. So you have this literature that patients are spiritual, doctors are less so, that patients expect it, that there's benefits when it happens, that there's harms when it doesn't happen, and there's a variety of benefits and there's a variety of harms. And this has been baked into the research of the literature. It's there, it's easy to PubMed. And so different organizations have come out with position statements. And so the professional organizations put out position statements that should impact physician practices. And so what the American Academy of Pediatrics wrote is that pediatricians should make the effort to be sensitive to and respectful of religious and spiritual beliefs and behaviors, keeping in mind that training and expertise are in caring for and treating the whole pediatric patient and aligning themselves with the best interests of the child. The American College of Physicians, which is an adult medicine professional organization, again, that physicians should screen for unaddressed spiritual and existential concerns in addition to addressing physical suffering. Physicians can extend their caring by acknowledging and exploring psychosocial, existential, or spiritual suffering. As patients struggle to find closure in their lives, active listening and empathy have therapeutic value in and of themselves, also written by Bernard Lowe. Surgeons aren't left out either. Physicians should recognize, assess, address psychological, social, and spiritual problems. And again, in JAMA, our calling is to cure sometimes, relieve often, and comfort always. And this is interesting. It says if a distressed and scared patient asks for a prayer and a physician sees that such a prayer could bring comfort, it is difficult to justify a refusal to do so. The American Association of Medical Colleges, in their learning objectives, I have to see if it's in the current one still, says that physicians must seek to understand patients' stories in the context of patients' beliefs, family, and cultural values. I mean, certainly as we think about social determinants of health and understanding the impact of context, that we don't just treat disease. I mean, this is an Osler quote that the good physician treats the disease, the great physician treats the patient. And certainly in the context of just the incredible, sort of amount of energy and, thought that has been paid towards the deep racism in our society, we're learning that social determinants of health can actually, and especially with COVID and just how it's impacted people of color and immigrants and our so-called essential workers, there is a push to think about patients more holistically in the context of who they are. And I think this is absolutely a time when we can also contextualize people in their spiritual beliefs out of sheer respect for the patients. Prayer is a little bit trickier. No matter what the survey is, the numbers are going to be slightly lower. So if 80% of patients want their doctor to ask about spirituality, it might be 40% of them want the doctor to pray with them. But again, like discussing spirituality, it is never zero. It is never 100%. Most Americans think a doctor should pray with the patient when the patient asks, but some think that the patient shouldn't. But again, it's never zero. It's never 100%. It's just a little bit less. Again, from the Annals of Internal Medicine, the Journal of the ACP, prayer can always be led by a patient. Physician prayer is appropriate when the patient requests it. And within the Penn Health System, because of what John Amen did in his research study, all the medical assistants in office visits are asking patients, so we screen them for domestic violence and have they had a fall, do they wear a bike helmet when they ride a bike, and they're also asked, should we be aware of any cultural religious beliefs that might affect your healthcare? John Amen's question was a little bit different. Do you have spiritual religious beliefs that would influence your medical decisions if you became gravely ill? He did this in a pulmonary clinic at Penn Presby. So it was sort of in the context of serious illness. And then Penn sort of has adapted that just for a little bit more broadly out of a pulmonary subspecialty clinic. A couple other mnemonics that have been published in the literature. One is FICA. Is your faith What is your faith or belief? Is it important to you? Are you part of a community? How would you like me to address these issues in your healthcare? So that's considered a spiritual screening questions. There is a recommendation for using open-ended questions. Does your faith in God lead you to think about CPR in a particular way? When diagnosed with a new illness, do you have any thoughts about why this is happening? Again, tell me more about that is probably one of my favorite questions when I am confronted with a culture gap that I have no idea how to thoughtfully bridge. I think just simply asking, tell me more, is a simple way to bridge that. Again, the American College of Physicians has adapted this. Again, Bernard Lowe, I don't even know if he's a Christian, but this has been his really strong area of research interest. There's other mnemonics. What is your faith? Is it available? Is it accessible? Is it applicable to you? Does it help you with coping? Does it make dealing with conflicts better or worse? There's an article that talked about how discussing religiosity can trigger people if they've had bad experiences. So if, for example, somebody is part of a church where they believe that HIV is a punishment from God, and you bring that up, it could actually make them less adherent with their treatment. So that comes out of a chaplain literature, which this is an article written for healthcare providers for non-chaplains. So the survey results, again, tend to be non-interventional studies. So it's not that they actually do an intervention where they have physicians, nurses, healthcare providers inquire and then map that out to improved outcomes. So these are hypothetical surveys for the most part. Would you want a doctor to talk to you about spiritual religious things that might affect your healthcare? Well, maybe the patient gets in the room and they realize they really want to talk about their heart failure, and they realize they don't want their doctor to talk about religion. So maybe the numbers overestimate how many people want to talk to their doctor about religious things, but also maybe they underestimate. So these are surveys, so you have to take that with a grain of salt. The numbers are never zero, they're never 100. And I think that has to be recognized because doctors like to move in binary ways. Either I always do this or I never do this. And a lot of people say, I never talk to patients about spiritual issues. Well, base it off of a couple anecdotes. And the answer is that they're going to miss opportunities to discuss and build relationships with patients. Even patients without beliefs may want to be asked because it acknowledges a part of who they are, and there's a variety of benefits, and I would argue that is also a standard of care. There's a couple things that I would caution you guys about. Is there's a separate literature on does spirituality and religiosity lead to improved health outcomes? And for example, can prayer, if you randomize control ICU patients to a group that gets prayer and a group that doesn't get prayer, does the group that gets prayer live longer and survive better than the group that doesn't get prayer? And there's a lot of arguments about what that literature shows. The literature can often suggest that people who get the religious intervention live longer. And the reason I don't really care to explore that part of the literature all that much is because I don't believe that that's what God promises us in the first place. So if there's a negative study where the people who get prayer don't live longer, God doesn't promise that we are going to live longer as Christians. He promises that he will be with us. He doesn't promise that we won't have trouble. He actually promises that we will have trouble and he will be with us in trouble. And so I don't have a felt need to try to prove that religious people live longer. Having said that, there's a really fun article that came out a couple years ago that you will get in email. And it is called Association of Religious Service Attendants with Mortality Among Women. And it was part of a longitudinal women's health study. And what they found is that comparing women who attended services more than once per week with those who never attend, adjusting for other illnesses, cardiovascular mortality was cut by 27%, cancer mortality was cut by 21%, and all-cause mortality was cut by 33%. And so they adjusted for comorbidities. They adjusted for a lot of things. And the reason I like this, two reasons. One is it's in JAMA Internal Medicine. And the second is it comes with an accompanying editorial about why we should research in a formal medical setting, why we should research and care about spirituality. And it's a very strongly worded editorial, and it's really good. There are some arguments that physicians shouldn't do this, that chaplains should do it, and that when physicians do it, we're stepping on the toes of our colleagues. There's articles in both the chaplaincy literature and the medical literature that suggest this. But again, in a primary care setting, I don't always have a chaplain right next to me. And I've learned to do all sorts of things, such as rudimentary physical therapy assessments and give some basic psychological therapy for patients. As a primary care doc, one of my jobs is to acquire skills, but not in a way that replaces my colleagues, but in a way that complements them. And I think that's true for every physician. Let me end. We only have a couple minutes left, so let me end there and see if you guys have any questions about this.
I can start with one. Josh, what I have trouble with, particularly at Esperanza, and I think maybe you may start to be having this issue in West Philly, is when you get folks from other religious backgrounds who are quite adherent. For example, the Muslim family that was from within the borders of Israel, but when I referred to it as Israel, they were offended. They're from Palestine. They're not from Israel, even though they lived within the borders of Israel. They're from Palestine. So how do you, other than, the tell me more questions, how do you navigate that?
Man, I step on so many toes when I practice medicine because I'm a naturally clumsy person when bridging culture gaps. I'm not good at it. And one is that you could put the patient in the role of teacher. I'm sorry. Boy, that's new to me, or I didn't intend that. And you give them the respect and you say, boy, could you just tell me a little bit more about that? Again, it's the whole idea that you're always moving towards people. Whatever it takes to move towards people. So yeah, that would be a simple response for me, I guess, is to apologize. I apologize all the time, but is to apologize and then just follow up and say, I would love to have you tell me something about that. or it sounds like this is really important to you and I didn't appreciate it. So yeah, tell me a little bit about how you would want me to address this.
Yeah. And you can even use the words like teach me about that. I need to learn. Teach me about that. I
Yeah,
don't
it
know.
makes the relationship very mutual
Mhm.
and very collaborative.
Mhm.
I mean, Jesus knows everybody from the inside out from before the eternity of time. I mean, I don't. So I have to ask people stuff.
I have a question. Have you ever gotten real pushback from any of your colleagues who are offended just because they are that percentage of people who are just offended having any religion cross over into what they see as a secular work?
So I have a couple of colleagues who, when my division chief presented this, felt that this was not a physician role. The discussion wasn't terribly emotional. It was just during a faculty grand rounds, and our division chief was pushing us to actually engage patients on spiritual issues, and some of the faculty felt that they could not do this, and I think that's fine, right? I mean, I'm not skilled at crossing every culture gap. Um, one culture gap that is just completely flummoxing to me is transgender issues. It's just a completely issue that I don't feel that I understand and I know how to bridge it, that I have the language and the frameworks and so forth. And so there we have, for example, an LGBTI clinic at Penn and a group of physicians. And I will refer a patient there if I feel like I can't meet that cultural need. Um, so I don't think that everybody has to be awesome at bridging spiritual culture gaps. This is more a justification for students and Christian healthcare providers that this is absolutely within the scope of practice. It is the standard of care, and it is a part of social determinants of health. It's about engaging the whole patient. Um, I have had patients who got offended and left. I had one patient who told me that he thought that religious people were stupid. He asked me if I had religious beliefs. I said yes, and he never came back to see me. But I've, you know, every doctor doesn't have to be right for every patient. That doesn't mean that I was wrong or that he was wrong. It just means that so be it. We're not a good fit. If I have a patient who says that they want, I mean, when I'm practicing in West Philly as a middle-aged Chinese guy, like no older West Philly patient ever comes saying, I want a middle-aged Chinese doctor that has a minivan, right? Nobody ever says that. So whenever they get me as a doctor, it's always some sort of culture gap. Um, maybe they want an older Black physician. We had Dr. Spencer, Dr. Johnson as two older Black physicians. They've both retired, but they built up a practice because of who they were. I can't replace them. I inherited their panel of patients, and I have a different relationship with the patients than they did. So I do think that atheist physicians or agnostic physicians or non-religious physicians are going to have to learn. And when I teach this, I do the same slide set for the family medicine residents. And the discussion is by and large by the non-religious residents asking me questions about how they can bridge it. It tends to be a fairly respectful discussion.
Josh, you talked a little bit about how patients can initiate prayer, but could you talk a little bit about how you might initiate prayer and how you actually bring that topic up and handle it?
Yeah, so the trick is if a patient initiates something, you can explore that area, right? That's the crack in the door that you can throw wide open. And so I have my teaser questions. So for example, I might say, a lot of patients are discouraged, but they have found ways to have hope even in the face of a new diagnosis of dementia or a new heart failure diagnosis. And then I just pause. And the question is, can I get the patient to then say, well, what is that? Can I draw them out? And if the answer is yes, then that opens a door to discussion of spirituality. Or if I ask a question like the patient says that they don't have any spiritual beliefs or they don't like talking about it, that's probably my favorite statement. They don't like talking about it, because if I ask why, then they end up talking about it, right? If somebody says they don't like talking about it, they have an issue. And if you ask why, they end up talking tons about it. So people who say they don't like talking about religion actually love talking about religion with emotion. And you just have to ask why. Now, in terms of prayer, I think one of the simplest things that can be done is just to say to a patient, is it okay if I pray for you later? I love praying for my patients on my own time. I'm going to pray for you as well. Is that okay? If they say yes, some patients might ask, can you pray with me now? And if they say yes, like these are like baby steps. And then if they say yes, you can say, well, sometimes I pray with patients now, right? You can just sort of walk your way to that point, right? And that's how I do it.
Have you had any colleagues at all use the power dynamic argument that, okay, you're in a position of authority with regard to their care, and so you're delving into stuff that's really, really, really personal, and you using your power and influence is not a good thing in that area?
I think this is where, as a academic Christian physician, you can be more specific about why you are bridging this gap. Like, that's what I like about this lit review is even if as a Christian, my goal is absolutely to love and impact the people around me on behalf of Jesus and to draw people to God. If I say the patient is suffering, the patient has a need, this is what's important to them, this is how I build a relationship, this is how the patient gets understood. If I can approach what is a generally emotional topic, but I can approach it from a more specific way, I have not had any colleagues. I have had colleagues raise that point, but then I've had answers for them that comes out of the literature. I mean, certainly the answers that matter most to us come out of the Bible, right? And so that Jesus tells us to make disciples of all nations is what matters most. But the language of academics is going to be like a JAMA article. So yes, so then I'm more specific. I'm not going to quote Matthew 28 to my Jewish colleagues, but I might open their eyes to some of the literature. So take this and use this. I think it's a way to thoughtfully approach what it means to be a Christian in a secular setting, a secular academic setting. Feel free to email me at any point. And I'm happy to share my Google Drive with you guys and of articles that I've sort of collated. I think it is, yeah. Yeah, I'll have to look it up. I can't remember what the URL is for my Google Drive. But I will send that to Holly, and she'll forward that to you guys. And then my email address is just my first last name at gmail.com. And I've had students take this literature, present it when they were asked to give a presentation at their school. I've had people take individual articles and present it like on their medical teams during rounds. And so there's a lot of interesting ways to bring this sort of literature up. And since it's not a literature that most physicians and academic healthcare teachers know, all you have to do is read a couple articles and you'll know more than other people. It's kind of simple. All right.
Nice.
I'll let you guys go. All right. Take care, you guys. Really enjoy your time at SMI. Just spend a lot of time encouraging each other, and feel free to keep in touch.